Hello, everybody. I apologize for the delay. This is Nurse Eunice with Florida Training Academy, and in today's video, we'll be discussing urinary and fecal incontinence and how does that impact your patient? How does it impact you as a CNA, as a nursing student who's going to be a future nurse? And as we do in every video, I will give you about 10 seconds to begin to receive your notifications before we begin. And hello, Barad. Hello, Tanae. It's great to have you here. Okay, so here we go, team. Question number one. What is the best way to prevent urinary incontinence in a patient who is bedridden? Is it A, limiting fluid intake, B, offering a bedpan regularly, C, keeping the patient in diapers all day, or D, avoid repositioning? Hello, team. I see you as you're coming in. All right, so how do we prevent urinary incontinence? How do we prevent them from being wet? Revealing the answer in three, two, and if you chose B, we don't want to restrict their fluids. What we want to do instead is we want to offer the bedpan regularly because that helps prevent urinary incontinence. You want to encourage them to void regularly. Void means to remove, to eliminate what's inside of their bladder. So, for layman's terms, it means to pee, but we don't want to be telling our patients to pee. So, voiding means to empty out the bladder, and that reduces bladder overfilling. Question two, the patient is experiencing fecal incontinence. Well, fecal incontinence, this is different from urinary incontinence. What dietary change can help improve this condition? A, increasing high fat foods, B, reducing fiber intake, C, increasing fluid intake and fiber, or D, reducing carbohydrate intake. So your patient has fecal incontinence. Fecal matter is seeping out. How can we improve this condition? I see A's in the chat. I see a C in the chat. We'll reveal the answer in three, two, and the way that you improve that is by bulking up the stool. And we do that by increasing fiber. But if you just give someone fiber without fluid, it constipates them. So fiber and fluid go together. So the rationale is increasing fluid and fiber intake promotes better stool formation and can reduce the frequency of fecal incontinence. Right. Question number three. Which of the following urine colors suggests a possible medical emergency? Is it light yellow, dark amber, bright red, or pale yellow? And this is easy. This is a no-brainer because we all know that anytime something, a bodily fluid turns red, that means that the person now has blood in that part of the body. So great job, team. The correct response is C. Bright red urine indicates the presence of blood, like active blood. It may signal a urinary tract infection, an injury. Regardless, it requires immediate attention. So if you're a CNA, you're calling a nurse. If you're a nurse, you're calling that doctor. Great job. I see so many correct answers coming through. Question four, a CNA notices that a patient's stool is black and tarry. What could this indicate? Is it A, fiber supplementation, B, dehydration, C, low fiber intake, or D, upper gastrointestinal bleeding? This one's a little tricky, so I'll accept two answers. But whenever that stool is black and tarry, and let's say it's never been black and tarry before, you should automatically be thinking ding, 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 alert, alert, alert. And yes, for all of you all who put D in the chat, you are correct. You want to be thinking about black tarry stool is caused by blood, the upper GI tract. That blood has been seeping out and is mixed with the gastric juices. And when it comes out of the body, it turns black. So black tarry stools could actually indicate that your person has an upper gastrointestinal bleed. Remember, if it was a lower bleed, it wouldn't be black because it would not have been mixed with the gastric juices. And let's go to our next one. Question number 5. What is the most appropriate action to take for a patient with urinary incontinence to prevent skin breakdown? Look, we have to make sure these patients' skin doesn't break down regardless of their medical condition. So, do you want to A, change the patient's position every 3 hours? B, apply heat packs to the area? C, use barrier creams and frequent perineal care? Or D, restrict the patient's fluid intake? How do we keep their skin from breaking down even though they are incontinent? All right, all right, all right. I see so many awesome answers revealing the correct response in three, two, and you got it. You knew it was the barrier creams, but you got to clean them first. So that's the perineal care. So, barrier creams and frequent perineal care help prevent skin breakdown by protecting the skin from constant exposure to moisture. And remember, as a CNA, as a nursing assistant who doesn't work in a hospital, who is not a patient care tech, you don't insert catheters. So a catheter has to be put in for a medical reason. A person who is wetting themselves doesn't need a catheter. They need a CNA who cares, who can get them to the bathroom more frequently, and of course, clean them once they are wet. Question 6. What is a common complication of chronic fecal incontinence? So this patient is leaking their fecal matter. It's just seeping out. What's going to happen? Is it going to be A, dehydration, B, skin irritation and breakdown, C, increased appetite, or D, urinary retention? I see you, Sherlyn. I see you. Let's see anyone else. I want to make sure I say it right. Stefania, I see you also. So great job. I see the correct responses coming through. If you chose B, you know that that fecal matter being stuck on someone's skin because it keeps dripping out, fecal incontinence. That exposure is going to cause skin irritation and breakdown. And that's going to make perineal care that much more important. So, just like babies can get a diaper rash, the adults can get it too, especially if they're not cleaned properly and they're just keeping their fecal matter or their urine all day. Question 7. What is a key infection risk associated with urinary incontinence? Is it A, skin infections, B, respiratory infection, C, urinary tract infection or UTI, or D, bone infection? Someone's just down, they're just sitting in their wetness all day. What's going to happen? They have urinary incontinence. And no one answered it incorrectly. I am so proud of you all. It is C. Urinary incontinence increases the risk of urinary tract infections due to prolonged exposure to urine and the possibility of that bacteria that's been sitting there harboring and growing entering the urinary tract. Question 8. A CNA notes that a patient's urine is cloudy. What is the most likely cause? Okay, I know you're going to get this right, but I still need to put it in here. It's going to be A, dehydration, B, poor hygiene, C, diabetes, or D, urinary tract infection. Look, you all are our private investigators. CNAs, nurses, and doctors, we are investigators. So when you take that person to the bathroom and they have the collection device in the toilet, and when they urinate, you start seeing like cloudiness, it's not clear urine, that should tell you right then that D, those are pus cells. That is bacteria in the urine. So D, cloudy urine is often associated with a urinary tract infection due to the presence of bacteria or pus in the urine. And of course, you notify your nurse, make sure you clean them up, notify your nurse, and then we will go ahead and order an official urine specimen to be sent to lab. Question 9. Which of the following is a strategy to prevent fecal incontinence? A, restricting fluid intake, B, avoiding fiber rich foods, C, providing only clear liquids, or D, implementing a bowel training program. Oh, you all were fast with this one. I love it. I love it. So I see Sheikah, Charmaine, Destin, Stefania, Barad, and all. So I see a lot of answers, but the correct response is going to be D, it is a bowel training program. It helps to regulate bowel movements, improving the management of fecal incontinence. So, something simple a CNA can do is just take them to the bathroom more frequently. What your nurse would be doing would be including medications and some other therapies, and also those reminders to get them to get up and go to the bathroom and walking around so that maybe the stool can form, and if they get up and start moving, because you're giving them fiber, and now you have them moving about, now when they go to the toilet, hopefully more of the stool is going to come out and they're going to be less likely to have the episodes of fecal incontinence. Question 10. A patient with a history of urinary retention suddenly complains of severe lower abdominal pain and inability to urinate. Ouch. What should you do? A, offer a warm drink. B, encourage deep breathing. C, notify the nurse immediately. D, offer more water. Hi, Miriam. I see you all. Great job. I'm over here doing my nurse dance, and you all are correct. Severe pain? Medical emergency. Get the nurse in there. So the correct response is C because the inability to urinate and severe pain could indicate a bladder obstruction. Maybe they have a kidney stone, you all, or acute urinary retention, which requires immediate medical attention. We're going fast today. We're doing 40 questions. I know that you all are our CNAs, our little mini investigators, our experts who are going to help these patients to better control their episodes of incontinence and be less likely to get those bed sores. So, question number 11. How often should incontinence pads be changed for a patient who is incontinent of urine? So you may call them chucks, but the correct term is an incontinence pad. Do you want to change it once a day, every 2 hours, or as needed? C, every 6 hours, or D, only when the pad is soaked? So this patient is having episodes of incontinence. How often do you want to be changing that pad, aka looking at your patient's perineal area to see if they're wet and changing the pad? And if you chose B is the right answer, not because it has every 2 hours. It's the right answer because it says as needed. Look, we don't know when they're going. So I need you to, every time you come in and check on your patient, just go ahead and check to see if they're wet and check that pad. Incontinent pads should be changed frequently, example, every 2 hours or as needed to maintain skin integrity and to prevent infections. Remember, when you're taking your test, it's not real world. I know if you have 30 patients, you cannot be in there checking someone's pads every 2 hours, but every time you do go in that room, if this person is incontinent, I do expect for you to at least ask if they need to go to the bathroom. And if they are unable to get up because they're bed bound, please check their bedding, check them to make sure they're not wet. Question 12. Which urine color might indicate dehydration? A, dark amber, B, clear, C, bright red, or D, pale yellow? Let's see. I hate that I missed what Nikisha said, but Miriam says you're funny, Nikisha. All right, so here we go, everybody. Everybody who chose A, you are correct. So dark amber is kind of like that orangey color. So dark amber urine is often a sign of dehydration as the urine becomes more concentrated when fluid intake is low. Are you proud of you? Because I'm proud of you. I see so many correct responses. Question 13. Which of the following is not a risk factor for developing urinary incontinence? Is it A, advanced age, B, pregnancy, C, prolonged immobility, or D, high fiber diet? Remember, the question said which is not a risk factor. And we'll reveal those answers in 5 seconds. Four, three, two, and here we go. Great job, team. It is D because all of those other things actually increase the risk of urinary incontinence. Let's go back and look. As you age, your muscles get weaker. Well, guess what? The bladder is a muscle. And so the bladder and those pelvic muscles will weaken, which means the person is more likely to have episodes of incontinence. Of course, with pregnancy and that baby weight sitting on top of the bladder, pregnant women can also leak urine. So, pregnancy will be a reason that someone could have incontinence. And if someone's just laying in the bed all day, remember, if they're not using it, they are losing it. So, they would also be at risk of having incontinence. So, for all of you all who chose D, you all knew that a high fiber diet was not associated with an increased risk of urinary incontinence, and you got the answer correct. All right, question number 14. Which of the following symptoms is most commonly associated with a lower urinary tract infection? Okay, so is it A, increased thirst, B, low back pain, C, painful urination, or D, nausea? Now, this one specifically said a lower urinary tract infection. So let's see if you can get this answer right. Hold up, hold up, hold up, hold up. I am so proud of you all. So many of you all have the right answer because if it is a lower UTI, you're not going to be experiencing too much back pain, but you will experience painful urination or dysuria. So if it's low, it hasn't traveled up high enough yet for it to affect the kidneys. So if it's low, it's usually the urgency, the burning with urination. But as that infection grows and goes farther up the urinary tract, that is when we start having the back pain because the kidneys are now infected. So I hope that helps you to understand the difference in the symptoms between a lower UTI and a upper UTI. All right, let's go to our next question. Question number 15. What is the purpose of a bladder scan in a patient with urinary incontinence? Is it A, to assess bladder volume and post void residual? B, to measure the urine pH? C, to identify kidney stones? Or D, to detect infection? I see Julia, Stefania, Adone, Elise, Chrissy, Barad. You all know that when that nurse tells you to go get that bladder scanner, it is because the patient is retaining urine, or we suspect that they are retaining urine. And so the answer is A. A bladder scan measures the amount of urine left in the bladder after voiding, helping assess bladder function and identify retention. So if the person's retaining, we're either going to have to straight cath them, which is when we take a flexible catheter, we insert it into the urethra, we drain the bladder, and then we remove the catheter. So that would be a straight cath. But sometimes patients need an indwelling catheter, and that's the one that's connected to the bag that hangs off the side of the bed. So that is how we would address a patient who is retaining urine. Bladder scan to confirm, and then after that, catheterization to remove that urine that's trapped within their bladder. Question 16. A patient is on medications that cause constipation. That's almost every medication, you all, especially those narcotics and pain medicines. What should you recommend to help prevent fecal incontinence? So, the medication causes constipation. What should you do as a CNA? Is it A, decrease fiber intake, B, encourage a low fat diet, C, increase fluids and fiber in the diet, or D, reduce physical activity? And this one is super easy for geniuses like you. So I know that you chose C. Congratulations. So increasing the fluid and fiber helps to prevent constipation, which will in turn reduce the risk of fecal incontinence. Question 17. Stay with me till we get to 40. Actually, if you stayed this far, come on, give me some thumbs up. And don't forget to share our videos with your family members, your friends. So many of you all passed your exams, and I'm so proud of you. And I love being your teacher. All right, so question 17. A nurse asks you to perform perineal care on a patient with urinary incontinence. What is your priority during this procedure? A, use only cold water to clean the area. B, clean from back to front. C, clean from front to back. Or D, apply alcohol based cleanser. I'm just upset that we even have D in there because that sounds so painful. Don't put anything alcohol based on someone's private area. So, yes, team, it is C. We always clean from the cleanest to the dirtiest, from front to back. So, cleaning from front to back helps to prevent the spread of bacteria from the rectal area to entering the urinary tract. Which of the following is a possible consequence of untreated urinary retention? Now we're on question 18. So if it's untreated, what is going to happen? They just keep holding urine, kind of like us hard-headed nurses, CNAs, and doctors. We don't go to the toilet like we're supposed to. So is it going to be A, hypertension, B, urinary tract infection, C, diarrhea, or D, weight gain? You've worked a whole 12-hour shift. You've taken care of everybody else and you have not used the bathroom. And then a seasoned nurse comes and says, "Hey, you need to go take care of yourself. Otherwise, you're going to get a B, UTI." So, a urinary tract infection can be caused by untreated urinary retention due to the stagnant urine and the stagnant bacteria being trapped in the bladder. So, make time to actually go to the bathroom as often as you can when you're working in healthcare. Question 19. A patient with a history of kidney stones presents with hematuria. What does this mean? Is it A, blood in the stool, B, pus in the urine, C, blood in the urine, or D, difficulty urinating? Let's see if you remember the medical terminology. We have so many videos on medical terminology. Do you remember? Do you remember? Do you remember that hematuria? Yes, let's see. Zebene, Barad, Brad with JMC, Blessing, Mila, Miriam, Danu, you have it. It is C. Hematuria refers to the presence of blood in the urine, which can be caused by kidney stones, infections, or other conditions. All right, question number 20. We're halfway done, team. Question number 20. A patient with fecal incontinence has a family history of colon cancer. What additional symptoms should you be alert for? So you read the H&P, you see the person has a history of colon cancer, and he also has fecal matter. He has fecal incontinence. So he has feces. He's always wet with fecal matter. So are you thinking about A, would you be alerted if they had bright red blood in the stool? B, constipation lasting 1 day? C, pale, greasy stools, or D, intermittent diarrhea. So, fecal incontinence, family history of colon cancer. Of course, anytime something is red, you have it. It is A. If it's red, high alert. So, bright red blood in the stool can indicate a lower should say upper. No, that's right. So bright red at the bottom, yes, that'll be lower. Lower gastrointestinal bleeding, which may be related to conditions like colon cancer. So remember, if it's bleeding up high in the GI tract, it's going to mix with the gastric juices. It's going to turn black. But if it's lower, like hemorrhoidal, if it's on the exit, that's when we start seeing the bright red colors mixed in with the fecal matter. Great. Question number 21. What is a key characteristic of stool that may indicate the presence of an obstruction in the intestines? Is it A, hard and pellet like, B, pale and clay colored, C, green and watery, or D, thin and ribbon like? We have an obstruction. If something's obstructed, it's going to be hard to pass through. And so here we go. It's not A. It's not A. I reveal the answer in 5 seconds. Give me another response. In four, three, two. Yes, you all. So, because the obstruction is so severe, only a slither of the stool can come through. So, that's why it is thin and ribbon like. Stools may indicate an intestinal obstruction that require further evaluation. So, it won't be hard and pellet like. Hard and pellet like is constipation. Obstruction is so much stool that's just packed in that only a little bit can escape. All right, so here we go. Question number 22. What does it mean If a patient's stool is pale or clay colored, our many investigators, patient has clay colored stool. Does that mean the patient is dehydrated? The patient has a bowel duct obstruction? The patient has consumed a lot of iron? Or the patient has a viral infection? And we'll reveal that answer in 5 seconds. It's not something you're gonna see often, but when you do see it, you're gonna be like, wow, why is the stool that color? And I'm revealing the response in three, two, and almost everybody got it right. It is B. Pale or clay colored stool can indicate a bowel duct obstruction. As bowel gives stool its normal brown color. So if the bowel duct is obstructed, that means the bowel doesn't mix and the color doesn't change. But let me tell you what else will give stool a clay color. Milk of magnesia, any of those different laxatives that they may take that are white, and also contrast. So if they had to have contrast for some reason, that could also turn the stool clay colored. So when you see something that's not regular, don't flush the toilet. If it's abnormal, don't make the patient too concerned. Just, hey, is this your normal? Have you done anything? Have you eaten anything different recently? And then you go and you put them back in the bed and you get the nurse to come in, and we can tell you, oh yeah, they had contrast yesterday because they had an x-ray or something, and that will help explain the reason why the stool is so white. All right, so here we go. Question number 23. What is the best position for a patient who is bedridden and experiencing urinary incontinence? Is it going to be A, supine, B, high Fowlers, C, lying flat, or D, semi Fowlers? Hmm. That is a good question. Positioning with incontinence. I see A's, I see B's, I see a D. We almost have the whole rainbow, the full alphabet. And for you all who chose D, you got it. So the semi-Fowler's position helps promote drainage or elimination, and it also reduces the risk of aspiration while still allowing access for incontinence care. When you sit someone all the way up in like a high Fowler's position, you're putting too much pressure on their tailbone, their coccyx area. So the reclining position, semi-Fowler's, is usually the best position because, of course, it helps with breathing. It doesn't tire them out as much. And then it's just easier to wipe them if they are in the semi-Fowler's position and they're having these other concerns also. Remember, not every patient can lay flat, but when you're cleaning them for the actual perineal care skill, you have to lay them flat. But when they're not being cleaned, semi-Fowler's would be a great position for them to be in. Question 24. What type of incontinence is caused by a sudden increase in intra abdominal pressure, such as sneezing or coughing? Is it A, urge incontinence, B, stress incontinence, C, overflow incontinence, or D, functional incontinence? Hmm, let's see what the team says. Let's see. Join says D, Blessing B, and Thea B, Elise B, Tanae B, Barad B, Join. I must have said it too fast. So it has B also, Chrissy, Mila. So everybody has it right. It is stress incontinence. So stress incontinence occurs when activities that increase intra-abdominal pressure lead to involuntary urine leakage. All right, great job, everybody. Question 25. A CNA notices a patient's urine has a strong ammonia smell. What should the CNA consider as a possible cause? Is it A, dehydration, B, the patient eats acidic foods, C, urinary tract infection, or D, liver disease? And you're not wrong if you choose B. However, think about your patient population and what you're feeding them in the hospitals. You are not feeding them a whole bunch of acidic foods. Their foods are usually bland, low fat, and not acidic. So think about the patient population you're going to be taking care of. And if their urine has a strong ammonia smell, more than likely it is due to C. It's due to a urinary tract infection. Question 26. What complication can occur from prolonged fecal impaction in a patient? Is it A, diarrhea, B, skin breakdown, C, bowel perforation, or D, frequent urination? Prolonged fecal impaction. Hmm. I agree with you all. I think it's C2. So, regardless of the answer on the next slide, if it's not C, that means the next slide is incorrect. I hope I did this right. I did it right, thank God. All right, so it is C. Prolonged fecal impaction can lead to serious complications such as bowel perforation, which is a medical emergency. Look, if it doesn't come out, it is going to go through. It's actually going to start coming out of the intestine itself. So that's why we have to make sure our patients are having a bowel movement. We monitor. It's like after the vital signs, the next question should be, are you urinating okay? When was your last bowel movement? Because we need to keep track of that. And at no point should a patient be going 2 and 3 days without a bowel movement while they're in your care, because you know better. You know that if they become constipated, it can lead to impaction, which could lead to perforation. Question 27. A patient with urinary incontinence is being discharged. What should be included in the discharge teaching to promote continence? Is it A, limit fluid intake to reduce urine production? B, perform pelvic floor exercises, also referred to as Kegels? C, avoid urination until the bladder is full? Or D, use a catheter regularly? Do, 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 do. All right, we'll reveal the answer in 5 seconds. Four, three, two, and all of you are right. Everybody's right. We're going to have them do their Kegels. The answer is B. So, pelvic floor exercises strengthen the muscles that control urination and can help to improve urinary incontinence. So, everybody, shh, it's our secret. No one hears us. No one knows what we're doing right now. While you're seated, just squeeze your butt cheeks, squeeze them in. And if you feel your pelvic muscles moving, you should be telling your patients to do their Kegels during every commercial break, especially if they're incontinent, because that's going to help strengthen their pelvic floor and hopefully reduce the risk of, reduce the amount of incontinence episodes they have. Question 28. What does green colored stool most likely indicate in a patient? Is it A, liver disease, B, a high iron diet, C, rapid transit through the intestines, that means the food's just rushing through, or D, a bacterial infection? And this one is hard, but I know you're smart and that you got it and that you know the correct response is. I see a lot of D's, I see C's, and so the correct response is, Barad, you got it. It is C. So green stool can indicate that food is moving too quickly through the digestive tract, not allowing bowel to fully break down. So looks like a lot of you learned something new. Put that in your notes so that when you see a patient whose stool is green, we'll be thinking about bowel ducts, pancreas, etc. All right, so let's go to our next one, everybody. 29. A CNA notices the patient's perineal area is red and excoriated due to urinary incontinence. What is the next appropriate action? A, apply barrier cream and change pads frequently. B, avoid changing the patient's position. C, increase the patient's oral fluid intake. Or D, use baby powder to absorb moisture. Hmm, excoriated. What does that mean? I know I have a lot of A's. I see B's. Let's see. I see more A's. I'm surprised that no one chose D, which was incorrect. So I'm proud of you all because we don't use baby powder in perineal areas any longer. So the correct response, everybody, is going to be A. Of course, clean them, provide perineal care, and then you would, of course, make sure you change the pad and apply the barrier creams. That will help to protect the skin from the moisture from the urine and to prevent further excoriation. Question number 30. We're doing so well. A patient reports this sudden onset of frequent, urgent bowel movements with watery stools. Which condition is most likely? Is that A, constipation, B, fecal impaction, C, diarrhea, or D, incontinence? Frequent, urgent bowel movements that are watery. And for everybody who chose C, you understand the definition of diarrhea. So, watery stools that are frequent and urgent are usually the classic signs of diarrhea. Question number 31. What intervention can help prevent urinary tract infections in incontinent patients? Is it A, reducing fluid intake, B, encouraging frequent voiding and proper perineal care, C, reusing disposable briefs, or D, avoiding any fluid intake after dinner? They are not toddlers. Your patients are not your kids. So we have to have a medical order to reduce or limit someone's fluid intake. So denying a patient fluid to prevent incontinence episodes will never be an answer. That is incorrect. So with that being the thought, that means that B is the correct response. Encouraging frequent voiding. So every 2 hours you go in, ask them if they want to use the bathroom. And maintaining proper perineal care help to prevent bacterial growth and to reduce the risk of urinary tract infections. 32. A CNA finds a patient straining to have a bowel movement. What should be the first action? A, offer a cup of water. B, stop the patient and notify the nurse. C, encourage the patient to keep pushing. D, assist the patient to a more comfortable position. And you know how patients sound, or someone sounds when they're grunting, they're trying to get it out, and they're just bearing down, but nothing's coming out. What would be the best option? And for everybody on 32 who chose B, kudos. Because when those patients are bearing down, they are eliciting a vagal response. They can actually lower their heart rate and pass out with you in the bathroom. So we do not want them to be bearing down because that could slow their heart rate. So what you're going to do instead is you're going to understand that straining can lead to complications such as increased intra-abdominal pressure, rectal injury, but also they could vagal and their blood pressure could drop and their heart rate could drop. So stopping the patient and notifying the nurse ensures that the patient is promptly assessed. Yes. So, yep. I'm sorry, we have to stop. All right, Miss Mitchell, let's get you to stop. Let me call the nurse in here so she can come and evaluate you. That would be the best response right then. Question 33. A patient complains of frequent urges to urinate, but only passes small amounts of urine. What should you consider as the most likely cause? A, stress incontinence, B, overhydration, C, fecal impaction, or D, urinary retention. Has the urge to urinate, but when she goes, only a little bit comes out. Why would that happen? It is D. Something's blocking. She has urinary retention. So, urinary retention often presents with frequent urges to urinate, but only small amounts of urine being passed due to incomplete bladder emptying. Someone else who would have this would be somebody who has an enlarged prostate because it's hard for the urine to pass over that enlargement. And so they could also dribble and not be able to fully void or empty out their bladder. Let's go to question 34 team. Question 34. What is a possible consequence of prolonged urinary incontinence that is not properly managed? Is it A, pressure ulcers, B, increased appetite, C, muscle cramps, or D, deep vein thrombosis or DVT? Prolonged wetness is how I read this. What is going to happen if your patient is wet for days? Prolonged urinary incontinence. Yes, team, that is right. Unfortunately, it can lead to the development of a pressure sore. So, prolonged urinary incontinence, if not managed with proper skin care, can lead to pressure ulcers due to constant moisture and pressure. Question 35. A CNA notices a patient's urine is dark brown. What might this indicate? A, dehydration, B, liver disease, C, excessive fluid intake, or D, normal variation. Yeah, that just happens. Some days your urine is going to be yellow, and the other days it's going to be dark brown. So we know D is not the response. So is it A, B, or C? Oh no, this one is tricky, right? But remember, we said before that with dehydration, it's usually dark amber. So if something is dark brown, that is beyond the normal scopes of dehydration. That could indicate, even though this one says liver failure, it could also indicate kidney failure. So dark brown urine may indicate liver disease, such as jaundice or hepatitis, and should be reported to the nurse immediately. When someone is septic, oh my God, their urine can look like sludge. And I've seen it happen a few times. So that means it's beyond the urinary tract at that point. That means that other organs or the organs that are higher up have also become infected and there could be infection in the bloodstream. So if it's dark brown coming out of their body and it's not fecal matter, please make your nurse aware. Question 35. What is a common cause of overflow incontinence in patients? Is that A, urinary tract infection, B, urinary retention, C, increased fluid intake, or D, nervousness? So, overflow incontinence. Hmm. Think of you pouring water from a pitcher into a cup, and the cup can only hold so much. So whenever it is overfilled, it starts seeping out. The same thing happens with the bladder. Whenever there is B, urinary retention. So great job, team. Overflow incontinence causes a constant urine leak or dribble. Urinary retention causes overflow incontinence, usually due to a bowel obstruction, enlarged prostate, or another problem that causes the bladder to get full and to start overflowing. How do we treat that? What you all are awesome at, getting them up to the toilet, aka bladder training. We can also give them certain medications. And if it's really, really bad, we have to go ahead and bypass that obstruction. We're going to go ahead and catheterize them. For your CNA test, remember, you can't do anything invasive. So CNAs do not catheterize for your CNA test, but what you do is you can empty the bag and you can also clean the catheter. All right, let's go to question number 37. You all are my warriors. I love you so much. Which intervention can help improve bowel movements in a patient with chronic constipation? Is it going to be A, limiting fiber intake, B, administering a stool softener as prescribed, C, encouraging a low fluid intake, or D, increasing protein rich foods? For this question, don't even think that you're a CNA. Just think, hey, someone can't have a bowel movement. How are we going to manage that? Because I need you to be thinking about what your patient needs. And so, even though you can't physically give it, you know that this patient who's bedridden, who's on narcotics, they should have B, a stool softener ordered. So, stool softeners can help make bowel movements easier for patients with chronic constipation, reducing the risk of fecal incontinence. But what can my CNAs do? You can give them food, foods that have a stool softener or laxative like effect. And so foods that are rich in fiber, such as papaya, plums, look, those prunes, dried plums, prunes, pumpkins, oranges, oats, they have a laxative effect as they contribute to the formation of fecal matter, making them an excellent option for loosening the intestines. So remember, as a CNA, you can help. your patients. You don't necessarily give a pill, but you can say, hey, Nurse Eunice, patient hasn't had a bowel movement in 2 days. Is it okay if I give them prune juice? Notice that I had you ask because there are certain patient populations that should not receive prune juice because it's high in sugar and high in potassium. And we don't want you to fix one thing, but then cause another medical condition to occur. Question 38. What intervention helps to prevent incontinence associated dermatitis? Dermatitis, skin infection, skin inflammation. Is it going to be A, using alcohol based wipes, B, limiting fluid intake, C, applying barrier creams and keeping the skin dry, or D, leaving the patient in soiled pads to adjust? Oh, yeah, Miss Lucas, I'm going to go to lunch. I'm just going to let you stay wet. You'll adjust to it. So, I know we're not going to do D. And because you all are super CNAs and super nursing students, you're going to choose C. You're going to apply the barrier creams. We're on close to our last question, everybody. We're on question number 39. So, which of the following is a risk factor for developing fecal incontinence? Is it A, overhydration, B, constipation, C, increased fiber intake, or D, increased potassium intake? Risk factor for fecal incontinence. Hmm, it's only one of these that really has to do with the bowels. So, by process of elimination, I am going to choose B. All right, so constipation is a risk factor for fecal incontinence because hard stools can weaken the muscles involved in bowel control. So it's going to stretch it out, which means and it can stretch out that sphincter, which actually controls the release of the stool of the fecal matter. So if the muscles are loose, that means that more of the liquid stool is going to be able to seep out. And we're on our last question, team. It is question number 40. So we did 40 of 40 in like 40 minutes. You all are amazing. So, what is the most common cause of involuntary urination? It's pronounced enuresis in elderly patients. Is it A, neurological conditions, B, increased physical activity, C, stress, or D, poor dietary habits? Involuntary urination means they can't control it. It's just coming out. Why would that happen? Let's see what you say in the chats, and we'll reveal the answer in about 5 seconds. I have tears in my eyes over here. I am so proud of you all. So many of you all got the answer correct. You know the response was A is in apple. It is the neurological conditions such as dementia or stroke. They are common causes of urinary incontinence as they affect bladder control. I'm so proud of you. Oh, you ought to see me over here. I'm giving you dabs. I'm giving you hugs because great job, team. I know that our patients are in great hands because we have caregivers like you. And so if you want our freebies, don't forget to go to our website, which is fltraining.com. Go to resources. You're going to see a whole bunch of free study guides, etc. And because, hold up, Medissa. I hope I mispronounced your name. Congratulations. I'm so proud of you. So everybody give Medesha congratulations on passing her CNA exam. And if I missed anyone else who has passed their exam because I really wasn't monitoring the chat, I do apologize. But you know I love you. And this week we're going to be on, I think, like 5 times with CNA practice tests. So I will see you all in a future video. Love you and have an amazing Monday. Bye, everybody.